First, I think that we should define the term acutely decompensated cirrhosis. This term refers to patients who are non-electively admitted to the hospital because of recent ascites, hepatic encephalopathy, GI bleeding, or any combination of these disorders. And having this in mind, you must know that ACLF is the most severe form of acutely decompensated cirrhosis. ACLF is characterized by the presence of one or more organ system failure among 6 major organ systems, and ACLF can be precipitated by, in Europe at least, in the US also, by bacterial infection, GI hemorrhage less often, and alcohol-related hepatitis. You must know that approximately 40% of the patients have only one precipitant, 25% at least 2 precipitants, and the remaining patients present without any precipitant. And this is important because the development of ACLF among patients who do not have any clinically apparent precipitant is an important point from the pathophysiological perspective, because we don't know exactly which mechanism trigger ACLF in this case. In fact, the diagnosis of ACLF is not so tough because we have very robust diagnostic criteria for each of the failing organ system. The failing organ system are the liver, of course, coagulation, brain, circulation, respiration, and kidney. And therefore, for each of the organ system except for the brain, we have a number: creatinine level, bilirubin level, INR level, SpO2 to FiO2 level, and mean arterial pressure. But for hepatic encephalopathy could be more difficult, and would be nice to develop biomarkers for diagnosis the presence and the intensity of hepatic encephalopathy. We can improve this diagnostic criteria for organ failure, maybe by refining the cutoffs, defining dysfunction and failure. We are working on this currently at EF CLIF, and also we can improve the overall assessment of the severity of patients by assessing additional organ systems. For example, we know that the skeletal muscles are very sick in this patient, and would be nice to assess skeletal muscle in these patients. Adrenal function also is very frequently altered in this patient, and therefore could be interesting to include the criteria for adrenal failure. Immune failure also is an important aspect of the syndrome, and gut barrier failure also is an important contributor to the syndrome. Therefore, in the future, I'm sure that we will include more organ systems to assess the overall severity of the patient. Pathophysiology-driven therapies are unmet needs, and currently we have only liver transplantation to cure patients, and I would say ICU therapies such as mechanical ventilation, renal replacement therapy, etc. But we need treatment addressing pathophysiology of the syndrome. And to me, there are two important points that should be highlighted. First, we know that systemic inflammation is a hallmark of the syndrome, but we don't know exactly what is the impact of systemic inflammation on organ function. In other words, does systemic inflammation cause organ failure through immune-mediated tissue damage, or is it an indirect effect of systemic inflammation through hypometabolism in peripheral organs? In any case, we have to understand which is the prevalent mechanism, and this is important to identify a clear target for novel therapies. Another aspect of the syndrome is the immune deficiency. Immune deficiency is a hallmark also of ACLF, and immune deficiency explains why these patients are prone to develop infection, bacterial infection, fungal infection, etc. Therefore, we have to understand which mechanisms are underpinning immune deficiency if we want to target directly immune deficiency in this patient. And the other point is that if you develop drug against systemic inflammation, you should take care of not worsening immune deficiency. Therefore, this is a very, very important question. I would say that the mission and the strategy we follow is relatively simple. EF CLIF is expert for running large, prospective observational studies among patients with acutely decompensated cirrhosis with the use of very granular electronic CRF. And also at EF CLIF we have a team which is skilled for data management, and therefore there is a continuous monitoring of data collected in these large observational studies. And therefore we collect very granular clinical data, and also these large studies are the opportunity to collect biological samples which are up to date mandatory to perform omics, and omics are also mandatory if we want to address unmet needs. This is the general strategy. And a very important point is that we identify in these studies the questions that should be addressed specifically by teams dedicated to translational research, and I would say also to translate in animal models. Therefore, animal models are not used to, I would say, to find the question, but to address the question. Again, the orchestration comes from the patient. This is very important. Once we have identified the relevant questions, we address this question using animal models if necessary, with specific labs which are expert for the specific question, and this is in general relatively effective. To me and for us, collaborating with GENFIT is very important because of the culture of GENFIT. The culture of GENFIT, if I understood correctly, is close to academic culture, and of course you are a pharma, but philosophy at GENFIT is that using basic research or translational research and clinical research is an important driver for developing new therapies, and therefore I think that collaborating with you is a win-win process. I would say EF CLIF was a peacemaker in the field of hepatology in Europe. In the past, we were competing, and we realized that competition was not so fruitful. Therefore, we decided to create EF CLIF. And the first achievement was the first description of an evidence-based definition of ACLF and diagnostic criteria. Then we refined and we identified a lot of upstream factors which lead to ACLF, including precipitants, including even socioeconomic factors, including genetic factors. For example, in Latin America, we have clearly shown that patients with Latin American ancestry or Latin American ethnicity are more prone to develop ACLF. And these findings are very important, not only for Latin America, but also for the US, where there are a lot of Latin American people. And we have now to understand why this person develop more easily ACLF. Another achievement was a relatively comprehensive description of the cellular molecular landscape associated with ACLF, because we already performed a lot of omic studies, and now we have a relatively clear view of the landscape. This is a very important point. First, we have to increase the awareness in the medical field. Very often I have to give talks, for example, for general intensivists, to convince them that ACLF should be considered as a very serious condition, which is reversible, which is treatable with liver transplantation, and therefore we have to, evangelize, I don't know if it is a correct term, this general ICUs. The other point is that we should collaborate more tightly with the association of patients. and to increase the awareness among patients about where we are, where we are going, and the great hope we offer to patients with liver transplantation, and hopefully with new therapies which are under development. The third aspect is to increase the awareness of stakeholders. Stakeholders include pharma and policymakers, the people who are deciding in the US, in Europe, everywhere, the public health policy. Therefore, we have a lot of work to do. Having ACLF is not the last stop. It's not a pre-mortem stage. Of course, it is a very severe condition, but if you look at the results of the Canonic study, which was the first large observational study performed by EF CLIF, you can see that patients who were admitted for ACLF grade 1, 50% of them had an improvement, including a full reversal of the syndrome. 50% of patients with ACLF2 also have an improvement during the first week. And almost 25% of patients who present with ACLF3 improve during the first week. Therefore, the take-home lesson is that when a patient presents with ACLF, intensive treatment should be engaged, because we don't know how the situation will evolve, and this is important. And in terms of chance for the patient, it is crucial. And also, when we make, I would say, the assessment of severity at 1 week, this assessment is very accurate for deciding for liver transplantation or not within the next 2 or 3 weeks. First, liver transplantation is rare, but more and more often used. Therefore, this is also an impact of the studies performed in the context of EF CLIF and other consortia. Second point, the general ICU management of these patients improved. For example, when I was in charge of ICU a long time ago, the mortality of patients was 100% in the ICU. And since then, we made very, very important progress. Therefore, patients can survive in the ICU. This is important. And of course, we need to have, again, pathophysiology-driven therapies which will help to bridge patients to liver transplantation. And these therapies should target systemic inflammation, but should not aggravate immune deficiency. This is the equation we have to solve. To me, these are therapies targeting systemic inflammation, but with no aggravation of the risk of infection. This is crucial. And also, we are running currently a randomized clinical trial. I didn't allude to, but it's an important trial of plasma exchange in very severe patients, and the interim analysis is very encouraging. And I think that the use of plasma exchange will be a game changer in the management of patients in the next years.